So today we'll discuss one congenital cyanotic heart disease case. So let's start.
Answer is already out, sir.
No, that is okay. That was decided, no?
Yes, yes, sir.
That was decided. Okay?
Please give.
Ready.
Okay.
I will start. So, good evening, everyone. Slides are not moving. Okay. So, informer being the patient himself and the mother of the patient. My patient is a 29 years old male resident of Kundapura, unmarried, hailing from low socioeconomic strata, not working, presented with chief complaints of bluish discoloration of skin and mucous membrane since birth, breathlessness on exertion since early childhood, and palpitations since 2 days prior to admission. The history started since birth. The patient is born of non-consanguineous marriage as a full-term normal vaginal delivery at hospital. He is a first child and there was no complication during perinatal period. However, the child was noticed to have bluish discoloration of skin and mucous membrane since birth, and the parents were informed that the child has a heart disease and needs cardiac evaluation. However, patient was not evaluated at that time. During first month of life, the mother noticed deepening of cyanosis during crying and sometimes during feeds, which used to normalize once the child is calmed down by parents after holding close to the chest, as described by mother. As the child grew, around 7 months of age, these episodes of deepening of cyanosis increased, and hence he was taken to the local hospital when the patient was informed that the child needs cardiac surgery. He was referred to Narayana Hridayalaya for the same. There, the parents were informed in Narayana Hridayalaya, the parents were informed that the patient needs stage surgery. However, due to financial reasons, no surgery was done at that time. After that, the child was growing. There was no delay in developmental or intellectual milestones. However, the child used to get breathless after playing with the kids of his same age group, and the bluish discoloration used to increase. At that time, he used to sit or lie prone, as informed by mother. These episodes decreased after 4 years of age. Also, the patient reduced his activity and avoid heavy exertion since then. Also, the mother noticed that patient was gaining less weight as compared to his the kids of his same age group. In 2009, that is around age of 17 years, the patient had headache and deepening of cyanosis, for which he was taken to Narayana Hridayalaya again. The parents were informed that he needs stage surgery. That time, bloodletting was done twice prior to the surgery. The post-operative course was uneventful. The patient was discharged after 10 days of surgery. The patient was regularly following up with Narayana Hridayalaya for 3 years after the surgery. However, after 3 years, he lost the follow-up. In 2015, that is at the age of 23 years, the patient had palpitations, which were sudden in onset, started at rest, regular, and associated with sweating and giddiness. When he was immediately taken to Kasturba Hospital, Manipal, where he was DC cardioverted in the emergency department. He was admitted for 4 to 5 days at that time and was started on some drugs. In this admission, 2 times bloodletting was done, and he also underwent a procedure via right femoral route and was informed that they should go ahead with the next surgery. However, the patient did not undergo any surgery after that till date, and he was doing fine until this admission when he presented with a similar episode of palpitations which occurred at night when he was sitting, which was sudden in onset and associated with sweating and giddiness. He was immediately taken again to KMC Manipal and was DC cardioverted in emergency department. There was no loss of consciousness at that time during this episode as well. Negative history. There is no history of recurrent respiratory tract infection in childhood, no history of forehead sweating or suppressed cycle, hemoptysis, prolonged fever, seizures, pedal edema, abdominal distension, chest pain, orthopnea or PND in childhood. Past history and birth history we have already discussed. As far as maternal history is concerned, there was no history of any cardiac disease, hypertension, diabetes, fever or any infection during pregnancy for the mother. family history, he has one sister who is 25 years of age without any heart disease. There is no history of any sudden cardiac death in the family. Developmentally, he achieved all his milestones on time. However, the weight gain was less as informed by mother. He consumes mixed diet. Appetite is normal. Bowel and bladder habits are normal. Sleep is adequate. To summarize history, my patient is a 29 years old male with history of cyanosis since birth, cyanotic spells in childhood, history of hyperviscosity symptoms and bloodletting in past, a history of one palliative surgery done and was advised stage surgery, and presented with palpitations in this submission.
Okay, Gaurav, you
Yes,
can,
sir.
if you want to have some clarifications, you can ask.
Yes, sir. Sir, regarding palpitations, ma'am, it was regular or irregular? It was not
Regular,
mentioned
regular.
in
I informed regular.
Okay, regular palpitation. And regarding surgery, it was done through the femoral route only, no, ma'am? Or it was a
No,
any
surgery was done.
or,
One open heart surgery was done, and
okay, okay.
after
Where
that,
is
when he
that?
presented with
Okay.
palpitations at later date, cardiac cath was done.
Sometimes, ma'am, some of the patient described that it was through central incision or it was a left lateral incision. If the patient has told you the
Central
history, because
incision. Central incision.
okay, okay, okay. Okay, sir. Then most of the
Yes,
so most of the
I
yes,
want
sir.
to ask a question, Monica. What happened? Two questions. One, is there a history suggestive of squatting?
Yes, sir.
It's
Squatting
not
episode she
history.
have mentioned.
No.
It is
She didn't
history of
Mentioned.
clearly say.
cyanotic spells.
She
He
had.
is
Cyanotic
lie
squat.
down prone,
She said
which is
squat.
a squatting equivalent. Sir.
That's why
Okay.
advertisements are there, but you said when she plays about, he sits down, but didn't mention whether it was a squatting procedure and or lies
He did
down.
not. He could not remember, sir. But lying down prone, his mother remembered.
Okay, okay. And
And that.
after the surgery, what happened? Was there an improvement after the initial surgery or
Hmm.
For
practically?
3 years, they regularly followed up, and he was doing fine after that. They were advised surgery, but he lost follow up after 3 years. Then
Did
around
his discoloration improve? I'm sorry to interrupt. Did his discoloration improve after surgery? Because patient can always
discoloration
uh,
improved. Discoloration
okay, okay.
improved. However,
After
when he
surgery. Okay,
had
okay, okay.
palpitations episode, that time his discoloration was even had increased. So bloodletting was done again.
Is there any symptom which is suggestive of right heart failure, like distension of abdomen?
No, sir. No, sir. I mentioned it in the negative history. There was no history of any distension of abdomen, edema, feet, or features suggestive of right heart failure.
Okay, fine.
And no headache also, no? Headache, headache and other CNS history.
Headache was there when he had
Okay, okay,
I mentioned it when he had palpitations, giddiness and headache palpitations he had.
When he came,
okay. No,
No
no
fever.
issue of CV, no CV. CV was not there. Any
No,
CVST
no,
was not.
no, no, no.
Okay.
now was the patient advised any medication following palpitation? Whether was the patient told
Yes,
that
sir.
just to
With
continue?
first episode of palpitations, 2 times bloodletting was done, cardiac cath was done. He was started on some medications. However, this patient means he continued medications till date. Despite medications, he developed another episode of palpitations.
And these medications, the medication that was advised to him was a single medication, and how many tablets was he consuming every day?
Sir, he was initially consuming 3 times a day, 2 tablets for
Okay.
a week or 2 weeks, and then he was on once a day dose. Sir.
Okay.
And ma'am, that onset, that cyanosis onset, it was on day one or it was
Day one,
you mentioned
at
day
birth
one,
only,
day one.
he had
Um,
cyanosis.
Okay, I
And
think
the day and degree of cyanosis, ma'am, can you that it was
No,
he was
that
deeply
much
cyanosed?
educated people, they were not that
Okay.
much educated, and
So
he
degree
was
of cyanosis,
evaluated at that time.
okay, okay. And any murmurs they have not shown at the time
Nothing
of
they have been,
diagnosis?
they haven't
Okay,
told, that means they were not informed. This is history, no? They
okay,
were not informed about
okay,
it.
for any murmurs. Okay. Yes, ma'am. It is
Okay.
clearly okay. Yes.
Okay, Gaurav, now proceed to discuss.
Yes, sir. So history is very typical history, sir. 29-year-old male with cyanosis since birth, sir, and since 1 month it has increased. And their history of cyanotic spells uh, with palliative surgery improvement in saturation. So first is, sir, cyanotic has decreased pulmonary blood flow.
Okay, very good.
Most probably top physiology.
Okay. In general,
Because
anybody who survives up to age of 26,
yes,
25,
sir.
most likely will have a low flow situation. Most of the high flow situations will they develop features of heart failure, and they very rarely survive to 20 and above. So somebody with a cyanotic heart disease has survived up to 20 and above. I will immediately think of a VSD-PS situation and a low flow situation. Okay, right. Yes. So we will think of one VSD-PS. Very good. Yes. What else?
Once, or it can be, sir.
Another important point for you to take up is that the child is cyanotic from birth. So you have to think
Yes,
of
sir.
conditions where the child can be cyanotic from birth. So what are the different physiological abnormalities which will lead to cyanosis? There are 5 varieties.
Yes, sir. First is, sir, top physiology.
Top VSD-PS top physiology. Very good. 2.
Another is, sir, it can be due to truncus arteriosus with PS, but this much of
What category does this?
Physiologies, we categorize cyanotics into 5 physiologies.
Yeah.
Basically, cyanosis with decreased pulmonary blood flow, which includes your top physiology, VSD-PS
Good.
physiology.
Very good.
Cyanosis with transposition physiology, cyanosis with admixture physiology,
Very good.
Eisenmenger physiology,
Very good.
and miscellaneous.
Yes. So whenever you think of cyanotic congenital heart disease, you should think one, of course, VSD-PS situation. Second, you should think whether to which category this patient belongs to of these 5. VSD-PS physiology, whether it is a admixture physiology, whether it is a this a transposition physiology or an Eisenmenger physiology, or is it a miscellaneous like pulmonary artery venous fistula or maybe Epstein's anomaly. So you have to think in which category this patient belongs to. So Gaurav,
yes, sir. Yes, sir.
for this you have to consider the patient is cyanosis from day 1.
Yes, sir.
Which one of these? Which one will have cyanosis from day 1?
Critical PS.
Can Eisenmenger have cyanosis from day 1?
No, sir. No, not possible. Sir. No.
Not possible. And can they have a cyanosis from day 1?
Transposition, cyanosis day 1. Tricusp atresia, cyanosis since birth. Pulmonary atresia, cyanosis since birth. Epstein's can have all types of cyanosis. It can even have cyanosis at birth.
Yeah.
And single ventricle sometimes can have.
So obviously cyanosis can occur from day 1 in admixture lesions as well as in transposition physiology. So what are the different admixture lesions, Gaurav?
Sir, DORV.
What do you mean by
No, sir, admixture can happen at the 3 levels, at the atrial level, ventricular level, or
can it occur before the atrial level?
Or the atrial level.
Can the admixture occurring before it reaches the atrium?
PAPVC, sir.
PAPVC.
Yes. Venous drainage is one. So start with TAPVC. Then what are the admixture lesions?
The DORV VSD.
No. DORV VSD is not admixture lesion. For admixture lesion, the whole blood, both the venous drainage at least should come to one chamber. Both the systemic venous drainage as well as the pulmonary venous drainage should come to one chamber. Then only we call it as admixture lesions. The classical ones are
Single Single atrium, single ventricle,
Single ventricle.
Tricusp artery,
Trungus arteriosus.
Yes.
AP window.
AP
No.
window.
No.
No.
No, it's a shunt.
No. What else? Epstein's anomaly. Sorry.
Yes, only
No, not Epstein's anomaly. Tricuspid atresia also can be considered as an admixture lesion because
Yes,
the whole blood reaches
common chapter.
the main ventricle, that is the left ventricle. So this also can be considered as an admixture lesion and can have cyanosis from day one. Transposition physiology also can have cyanosis from day one. But the pathology of phylolytic physiology, usually the cyanosis is delayed and usually occurs after a week or even 2 weeks later. So the cyanosis on day one is a point against the diagnosis of a classical tetralogy of fellow.
Yes, fellow.
Okay. So here we have got another clue. The doctors have told him that he requires a two-stage procedure.
Surgery.
So you have to think, what are the conditions where there can be a two-stage procedure? So we have thought that this must be either a admixture physiology or it must be a transposition physiology.
Transposition physiology. Yes.
On day one of these two, which one you? And also we have thought that there is a low flow situation, so there is a pulmonary stenosis. So we would like to know, or we would like to know one, what is the condition where there can be of these situations where there can be a two-stage surgical procedure.
Means it has to be
What is the basis of a two-stage surgical procedure? What is the condition in which you think of two-stage surgical procedure?
Actually, it is stage surgery, not two-stage. Initially they were informed stage surgery, then two-stage because he got operated at later date. He was informed at 7 months of age that he will require stage surgery.
Okay.
Not two-stage.
Stage surgery means that they would like to do one procedure.
Obviously.
And after a period of time when these things have settled down, they will complete the procedure by doing the next procedure.
Correct.
Okay, so what is the situation where a stage surgery is recommended?
Sir, if the child comes in deep cyanosis, sir, they will do a palliation and then will see that the improvement in the child, then they will go for a definitive repair.
There are many conditions. I am just asking you to enumerate few conditions where you would think that the patient may require a stage procedure.
As a top with critical PS, sir, they will first do a relief of the PS, and then afterwards, when the child improves, they can go for a definitive intracardiac repair.
No. In tetralogy of fellow, the stage procedure is not for that.
Not.
You recommend stage procedure.
Complete recall.
What is the situation where you would like to recommend stage procedure for tetralogy of fellow?
Absent.
When the Monika?
Yes, sir.
What is the situation? What is the background in which you would recommend stage procedure for tetralogy of fellow?
Stage procedure for tetralogy of fellows. In the very young age, sir, usually 6 months is recommended age for the child. If the child is symptomatic even before that, then only palliative surgery is indicated. Otherwise, intracardiac repair can be done as early as 3 months of age.
Usually, the child should be more than the age. I would consider child should be more than 5 kilograms weight.
5 kgs, yes, sir.
And only they will be the surgery is safe. The tetralogy of fellow, the stage procedure is recommended when the pulmonary arteries are very much underdeveloped. So you may sometimes give a shunt to the pulmonary system, allow the pulmonary artery to develop very well, and then do later a total corrective procedure. Because if you do a corrective procedure with the pulmonary artery very much underdeveloped, then the improvement will not be satisfactory. So in patients with a very much underdeveloped main pulmonary artery, and also the branches are not fully developed, then you recommend initial shunt procedure and allow the pulmonary artery to grow adequately, and then you do a procedure. So that is one stage procedure. Second, Previously, another situation, there was stage procedure was actually even large VST, there was a stage procedure. What is
Yes, sir.
the stage procedure for large VST? Gaurav?
PA banding and then surgery.
Banding.
Yes, sir. You can do a PA banding and then later the child has grown adequately. The PA, why the PA banding is required?
Prepare the ventricles.
Yeah, yes, otherwise the child will have torrential flow of blood into the pulmonary system. The patient will develop pulmonary vascular reaction, pulmonary vascular resistance, and Eisenmenger process. The Eisenmengerization can start the process, and even after corrective surgery, the child may progressively go for pulmonary artery hypertension. So previously it was recommended, but now it is not being recommended because the surgical technique has improved, the anesthesia has improved, things have improved, and the patient can directly go for a corrective procedure. And now it is recommended that if there is a large VSD, that should be closed as early as possible, so that the child can have a perfectly normal development. So that's another one. Another one.
Norwood in HLHS, hypoplastic left heart syndrome.
Yeah, hypoplastic left heart syndrome. You can have a stage procedure. What is the purpose of a stage procedure? In stage procedure, what do you do? Why do you want to do stage procedure? Why can't you do it as a single procedure?
The heart is not developed at.
Yes. Usually this is done when there is a univentricular physiology.
Yes, sir.
Whenever there is a univentricular physiology, then you consider stage. So it can be Tricusp Atresia, it can be single ventricle, it can be hypoplastic left heart syndrome, where there is only one ventricle is well developed. And then what do you do?
They'll prepare the ventricle for increased flow, sir.
Yeah, you prepare and you make the ventricle the systemic ventricle, and then you short circuit the heart and allow the systemic way of blood to drain into the pulmonary system, provided the pulmonary vascular resistance is less than 2 Wood units. The most important point is that the pulmonary vascular resistance should be less than 2 Wood units for you to direct the blood into the pulmonary system, and then the single ventricle can perform as the systemic ventricle, pumping the blood to different parts of the body. So that is why the hypoplastic left heart syndrome patients do not do well, because the right ventricle is made to function as the systemic ventricle and they don't perform very well. While when you think conditions like single ventricle or tricuspid atresia, they can perform much better, because the ventricle which is pumping the blood to systemic circulation is the left ventricle.
Left ventricle.
So these are the few things that we have to consider. We should consider that this is a. So out of this, what do you think is most likely? We have considered few conditions. We have thought it is a low flow situation, VSDPS. Then we thought it must be either a transposition physiology or admixture physiology. Of these two, which one you think is more likely?
Sir, admixture physiology, sir.
Yeah. Why are you excluding the transposition physiology?
Sir, because child has 29 years since he has survival is there, sir. Survival is more in the.
Yeah, that is true with the admixture physiology also. Patients with admixture physiology and also transposition of relative cells, transposition physiology can survive. Transposition, of course, there should be good mixing of the blood in the atrium. There should be large receptor defect, and the patient has got if associated pulmonary stenosis. Yes, they can survive. So PS is the one which actually protects. So this patient has got. There is no doubt about it, because PS, without PS they cannot survive before on the age of 20.
I have seen one patient, sir, 22 years old, mother not willing, well-to-do family, mother is not willing for any surgery, 22 years old, transposition of great arteries, dextrocardia, but common atrium and PS.
Yeah.
So he has survived without any surgery.
No pulmonary stenosis.
Pulmonary stenosis is there.
Yeah.
Pulmonary stenosis is there.
That's right. See, In a transposition of great arteries, if there is associated pulmonary stenosis, then the next point which decides the survival is the mixing of the blood. So in your case, actually, it was a single atrium. So there is an excellent mixing of the blood, and that is why the patient survived.
Only thing means he had cyanosis, he had spells also. However, he had sir, recurrent seizures and brain abscess, 3 episodes.
Oh, I see. Oh, so he has developed adequate complications. But
Yeah.
the survival is mostly related to that he has got associated pulmonary stenosis, thereby protecting the pulmonary vasculature, and he has got an excellent mixing of the blood because you said he has got either a very large ASD or maybe a single atrium. So there is an excellent mixing of the blood. So these are the 2 points which decide whether the child can survive or not. Of course, I agree with you that patients with the transposition of great arteries can develop a number of complications, and their survival is very unusual. So when it is 22 years, we usually don't think of transposition of great arteries as the the first diagnosis. So in this situation, another point is the transposition of great arteries. When you look at surgical procedure, what is the surgical procedure for transposition of great arteries, Gaurav?
Sir, arterial switch, sir, arterial.
Yes, switch surgery, arterial switch. Is it a stage procedure or a single procedure?
Uh, Depending upon the compliance, sir, sometimes they do a banding also to prepare the ventricle.
No, no.
Arterial switch is a day one of surgery, done within 1 month of the birth. Later, after 1 month of age, atrial switch is done. Hello, sir. Am I right, sir?
Mhm.
I think, sir, कुछ internet issue आ गया, I guess.
Mhm.
Gaurav, I
हाँ,
haven't
surgery
read
पढ़ाई
much,
नहीं मैंने.
okay? I haven't read
मैं
much, okay? You just answer.
Ma'am, I have not read the surgeries. What to do?
No need to read surgeries. It's okay.
I will come back. Ma'am, your exam in March?
Sorry?
Your exam is in March or?
I am already DM cardiology.
No, this DNB exam, your DNB exam.
DNB exam just now, next week, but I don't know. I am going my hometown. Let's see. It's
So
16th.
March. Okay. March they will.
What, they have changed the date? It was 16, 17, 18, 19 just now. Last week I checked.
Okay. Now, few of my friends they have in March. Okay.
How come? Maybe then I will have to recheck because 2 days back I checked it was 16, 17, 18, 19 December.
Oh. No, actually they are completing 3 years in June, July. Only, that's why they.
They may be appearing then.
Hmm. Ma'am, for surgeries, which book you read? Surgeries.
I have presented, these topics.
Okay.
My friend, so we had prepared quite a lot from some thoracic surgery books and all. We have separately presented these topics. Means Fontan and Fontan complications. It was around 1.5 hours talk for each of us. Both of us presented it that way, like. And my husband is a cardiac surgeon.
Okay.
You're from which institute, Gaurav?
I am in Kerala, Amla Institute.
Okay, okay. I think something went wrong with sir's this thing.
Let me call to the doctor, just a minute.
Yeah, sure. Meanwhile, just let me tell you, this is very important topic. Fontan and Fontan surgery, it means Fontan complications. It can come as a long question also. So both the
Yes,
topics
ma'am,
which I
yes, ma'am.
have covered, continuous murmur, Fontan complications, Fontan circulation, all these are long questions. However, we prepared as
You
presentation.
told midline surgery. No, midline surgery.
Sorry.
You told midline surgery was done, no?
Yes.
Midline surgery. Then generally total cardiac repair is the.
No, not really. Not always.
So, sir, ma'am, there is a network issue with doctor's laptop. Sorry, network issue. So, I am sharing a Zoom link to him. He is rejoining.
No problem. No problem. Actually, Gaurav, all cardiac surgeries are usually midline sternotomy. Okay, only few are done. Only few are done lateral thoracotomy. So you should
Actually,
know.
I presented. Yes, I presented one case. She was having left, so BT shunt was done.
No, I will tell you. I will tell you. See, so listen. Left thoracotomy is usually minimal invasive CAPGs, closed mitral commissurotomy, or BT shunt or PDA ligation. Okay, this is left thoracotomy. Note it down if you want. And the right thoracotomy is usually minimal invasive ASDs, and they do minimal invasive. I think sir is
Doctor, am I audible?
Yes, sir, is joined. Sir is.
Okay. I think something happened to my net connection. Okay,
Yes,
fine.
Yes, sir. Sir, just he had one doubt. Can I clarify,
Yeah,
sir?
yeah.
Yeah. So he was asking me about why he has midline scar. So Gaurav, most of the cardiac surgeries are done midline. However, few surgeries you must note down. Those are done left or right thoracotomy. So left thoracotomy, you have minimal invasive CABG, closed mitral commissurotomy, and BT shunt and PDA ligation. Okay. And right thoracotomy is minimal invasive AST closure and MVR. Now, upper mid sternotomy is done for minimal invasive AVR. So, this means you should know exams ke liye.
And actually, the closed mitral commissurotomy, it is actually an anterolateral thoracotomy. While for PDA, very often it is posterolateral.
Yes, sir.
Yes. So, by looking at the site of the incision, you may be able to draw some conclusions regarding what may be the procedure. And most of the open heart procedure almost always is done through midline, and that is why because the going on bypass, on pump, all those things are easy when it is a midline incision. So this patient has undergone a midline incision.
Yes, sir.
Okay, right. Go ahead. So I asked you a question. What are the other than the stitch surgery? What are the other surgical procedures for transposition of great arteries? Monika?
Yes, sir. Sir, within 1 month of age, usually on day one only they operate for, in emergent situation to facilitate mixing, we can do balloon-atrial septostomy, which is a transcatheter procedure. Then that is BAS.
One question. Why
surgical?
Why, Monika? One question. Why is it that they recommend that surgery should be done as early as possible? Because in a patient, especially in a patient without BSD, you have to. That's a very good anatomy for corrective procedure. and the procedure should be done as early as possible. Why is it that the surgeons recommend, or the cardiologist also recommends, that surgery should be switch surgery should be as early as possible? What is the reason?
First of all, sir, in this such complex congenital heart diseases, particularly transposition, the PVR will be established even before 2 years of age.
Okay.
It is the early development of pulmonary vascular disease.
No, you cannot wait up to 2 years. You have to operate, mostly you have to operate within a month.
Within a month. Within a month, arterial switch.
I am asking what is the reason? I am saying the patient is not having any VSD, not having any large PDA. There is only a small ASD or maybe moderate sized ASD. Wow, what should still you have to recommend that the surgery should be as early as possible? What is the reason? The reason is that
deconditioning of the ventricle.
Patient will be profoundly cynosed, sir. There will be complications related to cyanosis as there is no adequate admixture. So earlier surgery will save the shock, acidosis, and further complications of hypoxia and cyanosis. Second thing is growth of the child and the vessels. Earlier we operate the vascular growth, sir, will be circulation dependent. I am not able to put it in exact words, but this is what I think.
One reason is that, see, the RV is pumping to pulmonary artery, and the LV is pumping to pulmonary artery, and the RV is pumping to the systemic circulation. So, see, if the patient is not having any large BSD or large PDA, the pulmonary vascular resistance regression will take place normally. That will, once the pulmonary vascular resistance falls, regression takes place normally, the LV will be pumping to a low pressure.
Yes, sir. Deconditioning.
Low pressure lungs, pulmonary circulation.
Sir, voice is not clear. No?
I think it is stuck.
And one PA bending also through dichotomy, no ma'am? PA bending also. Hello?
How will you do PA bending? Now.
I think I read somewhere. PA bending also they are doing through that.
It is in the circulations are not in series. If they are in parallel circulation, if there is no intercirculatory mixing, if you obstruct one of the thing, it will cause ventricular volume overload, isn't it? Pressure overload, rather. You're getting my point?
No, for preparing the ventricle, that was.
For preparing the ventricle.
Yes.
For preparing ventricle is different.
Yes.
We'll wait for sir.
No, there was what to do.
So far we have reached to the diagnosis of admixture physiology. Top physiology is also possible, no, because cyanotic spells are there.
Eisenmenger is also 29 years old and last.
But he has cyanosis since birth, no.
That is only.
It is very important. So Eisenmenger is almost out. Any one of the top physiologists. So you enumerate all. That is okay. Sometimes Even classical TOF, severe TOF, can have cyanosis since birth in 20% of 20 to 25% of the patients.
They told critical PS, no, ma'am? Critical PS. But
All TOFs
that
are
was,
critical. All TOF will have critical PS. It is the pulmonary blood flow which will determine cyanosis. All TOFs have severe PS. There is no mild PS, moderate PS. ऐसे कुछ नहीं होता है. All TOFs are critical PS, severe PS. Because it's not just the infundibulum. Most of the times it is infundibular plus valvular. And entire pulmonary RVOT usually has hypoplasia. Perloff has given it very nicely if you are reading Perloff. There is nothing like Perloff for TOF.
this host, Riddhi is there host or who is the host? No.
I don't know.
I mean, AV canal defect should come last. No, single ventricle should be ऊपर होना चाहिए.
वो एक्चुअली मैंने आज ही डाला है. एवी कैनाल डिफेक्ट आज ही केस देखा मैंने इसलिए डाल दिया. इसका नंबर भी चेंज हुआ. हाँ आज ही देखा एक केस इसलिए डाला मैंने अभी. Actually, I didn't want to put it. I never put that in this case, but for discussion sake, I have kept it.
You are still in Manipal, ma'am, or where are you working now?
Yes, I am in Manipal.
Okay, okay.
I saw a wonderful case today. That's AV canal defect.
Manipal, this is main Manipal Kasturba Gandhi Medical College, or this is one more? There one.
Manipal.
There are two more.
Kasturba.
Okay, okay. I was getting it, but the fees this time it was 25, so I choose Amla Hospital.
You should have opted.
Oh, actually, I discussed with Sudhakar Rao sir is there, no?
What is it?
Actually, both are MCI recognized seat, and the cost was more there in 25 years.
We are getting tremendous hands-on here.
No, hands-on we are also getting.
How many cases like?
Yeah, hello. Sorry for interruption. Just want to inform one thing. Dr. Rajan is having some issue with joining. So he will be joining. He is trying to join. So he might join soon.
We'll wait for him.
Okay, sure. Actually, he is having some hardware issue with the device. So probably he solved the issue. Then after that he will join.
Some hardware problem or net issues only?
I mean, there might be some hardware or any technical issue.
Okay.
I will talk with you.
Okay.
Okay, what do we do in BT shunt? Just we'll discuss a bit before sir, so that sir can join us. We'll learn more. Gaurav,
Yes, ma'am. Yes, ma'am. Yes, ma'am.
BT shunt is what like?
It is a palliative procedure for from subclavian to the
Subclavian,
pulmonary artery, subclavian to pulmonary artery, left subclavian
subclavian artery to pulmonary artery.
to pulmonary artery. Well, there are two types. One is classical. Sir has come.
Oh, okay. I think something happened to my connection. Okay, right. Gaurav, yes, you are discussing some point.
No, sir, I
So
just asked what is BT shunt, and he said he is not well versed with surgery, so I thought we'll discuss it out.
Yeah. Okay. So we can discuss about the BT shunt also. That is not a problem. So Monika, you can give a short description so that he understands about the BT shunt, the Gore-Tex shunt, and the central shunt. There are three types of shunt which is now being practiced. Now, of course, the central shunt is not being practiced nowadays, and BT shunt is also not being practiced nowadays. And it is the Gore-Tex shunt. And why Gore-Tex shunt is superior to BT shunt? Monika, you can try that.
Why Gore-Tex shunt? So there are classical BT shunt and modified BT shunt
Okay.
and central shunts. So classical BT shunt is usually end-to-side anastomosis.
Yes, that's the problem with the classical BT shunt. It is an end-to-side anastomosis.
End-to-side.
You have to sacrifice the
Artery.
subclavian artery, and some of these patients can. So where does the the other subclavian get the collateral flow from? Gaurav, where does the
Yes, sir.
if the shunt is done on the left subclavian artery, and how does the subclavian artery receive the collateral flow?
It's from the
Descending thoracic aorta.
descending.
No. It is not from the descending thoracic aorta.
And the the other branches of the thyrocervical trunk, which is going posteriorly, sir.
No.
Actually, cervical plexus means
No.
cervical vessels.
No.
Thoracic vessels.
No, the most important communication is actually the vertebral artery.
Okay.
Actually, the incision is done just before the vertebral artery, and these patients can have sometimes the subclavian steal syndrome, because when they exercise with the hand on which side the surgery has been done, the patients can draw blood from the opposite vertebral artery, and the patients actually can have a syncope. So, subclavian steal is one of the symptoms of BT classical BT shunt. Classical BT shunt is, as Monika was telling, it is an
end-to-side.
Gaurav, which artery is end and which artery is side? Is it end?
End is subclavian side. End is subclavian side.
Subclavian is?
Yes.
Is it side? Is end artery or side artery? Anastomosis of the subclavian arteries to the side of the subclavian artery, to the end of the subclavian artery.
To the end of the subclavian.
Yes, it is the end of the subclavian. And on which side is usually BT shunt done?
Generally on the opposite to the arch, sir. Opposite to the arch.
It is usually done on the opposite side as the arch. If it is a left-sided arch, it is done on the right subclavian, and if it is a right-sided arch, which is done on the left subclavian. Okay, right. What is this? Monika, can you explain how the modified BT shunt or the Gore-Tex shunt is superior to BT shunt?
Modified BT shunt is side-to-side anastomosis, and usually they use the Gore-Tex conduit.
Yes. And the greatest advantage is that you need not sacrifice the
subclavian artery.
And you can always see, you can give a temporary modified BT shunt. The patient's pulmonary arteries can grow very well, And when you do a corrective procedure, you can completely restore the circulation without any problem. That's a great advantage. Okay, central shunts are not being done nowadays because what is the problem of central shunt, Monika? What is the problem of central shunts?
They distort the morphology.
Yes, of course. How does they? How can they distort the morphology?
Because we are, sir, central sense, like, sir, we are communicating between the main pulmonary artery and the, sir, ascending aorta. Then, sir, manipulation is too much, has to be done.
No, no. Can you mention what are the central shunts and where does the shunt is connected? From which to which artery?
The one is Watson.
Yes.
MPA with the descending aorta, sir.
No, it's RPA. Watterson is ascending aorta to the right pulmonary artery.
Very good. And port shunt is
Descending aorta to left pulmonary artery.
very good. That is how the shunt is being done. The problem with central shunt is that usually shunt is usually very large, and these patients can actually go in for an Eisenmenger reaction, and
Yes,
they
vascular
they
disease.
develop pulmonary vascular resistance that can go up, and they develop Eisenmenger reaction, and they actually come with a severe pulmonary vascular resistance pressure going up. So Watterson Gully shunt as well as the port shunt both are not being recommended now, and Gore-Tex shunt, which is the modified PT shunt, is the most ideal one, and that does not sacrifice the subclavian artery, and also shunt is sufficient enough to provide good flow to the pulmonary arterial system, and can allow the pulmonary artery to grow well, and later you can even do a total corrective procedure if you want to do a stage procedure. Okay, right? Yes. So what are the other two? What are the names of these two surgical procedures done for corrected transposition? Transposition of the arteries. Gaurav, one you said.
One was arterial switch we have discussed.
Yes.
Then was
And it's the atrial switch.
Atrial switch. What is the atrial switch and what are the procedures of atrial switch?
Raskin procedure.
Yes.
No.
Raskin procedure is not atrial switch. It is the what is the Raskin?
BAS. Balloon atrial septostomy.
Yes, it is a balloon septostomy is known as Raskin's procedure. So for the atrial switch, what are the two surgical procedures? The mustard procedure and the sending procedure.
Sending procedure and mustard procedure.
The sending procedure, the mustard procedure is not recommended because that can result in the
atrial arrhythmias.
Atrial arrhythmias and also sometimes stenosis of the veins connected to the atrium, and hence now the in patients where the switch surgery is not possible and surgery is cannot be done, then the procedure is sending procedure. What is the problem of sending procedure? Why it is not the preferred operation? Why the switch switch surgery, arterial switch is the preferred operation, preferred procedure?
Correction by atrial switch will be only the physiological fulfillment.
Yes.
And the ventricle, sir, right ventricle has to face the systemic circulation in case of atrial switch, which will fail later also.
Yes. So there's a problem that since the right ventricle is facing the systemic circulation, by second decade, even by about second decade, many of these patients can go for right heart failure, and they may develop gross right heart failure, and their life expectancy is significantly restricted. What is the complication that can happen for switch surgery? Switch surgery can have
yes, sir, that can also lead on to say this RV.
No, there is no RV there. No, there is no
LV.
problem RV because the RV is pumping to the pulmonary system and LV
Yes, sir.
is pumping to the systemic circulation. So there is no problem there.
Sir, in arterial switch, we have to give graft from the
Coronaries, basically coronaries, coronaries can get obstructed. Obstruction of coronaries.
Nowadays surgeons are so good, there is no problem. It is not related to surgical procedure. It is related to the presence of which is the valve which is supporting the systemic circulation in switch surgery.
Pulmonary, sir.
Pulmonary arteries, pulmonary stenosis.
Pulmonary valve.
Circulation. So the pulmonary valve over a period of time may not be able to sustain
PR.
high pressure.
The pressure.
Patients can
PR
go
channel.
in for pulmonary regurgitation, which is actually
Yes,
aortic,
sir. PR. Yes.
aortic regurgitation. Okay.
Sir, in top also they have written post-op PR. Sir, in top also they have written post-op PR as a complication.
Yes,
Top
yes.
surgeries also.
Yes,
Now,
because we are doing
yeah, that is patients who undergo total repair, especially if the RV outflow is narrowed down and the annulus is also significantly narrowed, then they have to repair the RV outflow as well as the annulus by doing a patch. And this can result in some degree of pulmonary regurgitation, which actually can progress and the patient can develop right heart failure. Previously, it was thought that pulmonary regurgitation may not give rise to much of a problem, but we now know that the pulmonary regurgitation also can give rise to problems, and as far as possible, this should be avoided. And nowadays, when the total correction is done, a patch which results in pulmonary regurgitation is as far as possible avoided. Okay. Now, Gaurav, you put your diagnosis and then we'll go for the physical findings and then further discuss. Put the
Yes,
diagnosis.
sir. Sir, differential diagnosis, sir, top physiology and it's
The patient is having VSDPS because
yes, sir, VSDPS.
low flow situation, the squatting equivalent, cyanotic spells all put together, and the child has survived beyond 20 years. I think VSDPS is there. Yes. What more?
Yes, sir. Sir, DORB VSDPS, madam has put that, yes. DORB VSDPS is one of the...
DRV, I would put lower in the list because
single ventricle, sir.
yeah,
Second will be single ventricle.
yeah, single ventricle
Yes.
can be definitely considered single ventricle physiology because we are considering a stage procedure. So I would go for a physiology where
single ventricle or tricuspid atresia.
yeah, tricuspid atresia or single ventricle both can be included in our differential diagnosis. Yes. Anything else?
Sir, one more. Just now you told us, sir, post-procedure Eisenmenger, that also we can put.
No, the child is diagnosed from day one. So
Okay, sir.
I will stick to single ventricle or I may also both these conditions should be, we cannot differentiate between these two, single ventricle or tricuspid atresia, both should be considered. There is a BSD-PS physiology also. Do you think that this patient is having dextrocardia from the story?
No.
No, dextrocardia is not an associate form. If you are thinking of tricuspid atresia, dextrocardia is not a common accompaniment. So dextrocardia has got different lesions. Okay, now so she has said character transposed ungulate arteries. What about character transposed ungulate arteries?
Sir, from history, how will we determine dextrocardia?
No, that's you have to get a clue. If usually the patient or the mother says that the organs are placed on the other side. So usually when they're taking the story, I usually ask the mother or the patient who is now 22 years whether any doctor has told them whether your liver is on the left side and the stomach is on the right side or the heart is on the wrong side. So that from the story you can get an idea whether the child is having a dextrocardia or the organs are malposed, so that we can expect the venous anomalies, we can expect complex congenital heart disease. So all those things can be thought of by asking the patient whether somebody has told him that your organs are on the wrong side. Usually,
Patient per se, his relatives or his mother didn't give history of, but I also didn't ask specifically, sir.
It's better as a part of the story. It is better to ask, especially so that you don't miss it. Because sometimes during the in the anxiety of the examination, students may miss dextrocardia. So it is always better to ask in the story itself whether any doctor has told you that your heart is on the wrong side.
Okay.
Okay, I think she has mentioned out of these, which one you think is the first one? She has mentioned all the important conditions. So, what do you think? Which one you think is the first one?
The single ventricle top physiology will be.
I would go for
Uh,
tricuspid atresia with VSDPS as the first one,
okay, sir.
and then single ventricle with top physiology as the number two. What about
Okay.
AV canal with the tetralogy of physiology? What is the common situation where you can get AV canal defect with the TO of physiology? If you are getting this, what is the common association that you can think about?
Down syndrome.
Which one?
Downs.
Yes, Down syndrome.
Downs.
So when you are thinking of tetralogy of like situation in a Down syndrome, you should always consider a possibility of total AV canal defect. Okay.
Here there is no history of any Downs, sir. Here there is no.
Yes, I just in this patient we are not considering that. I won't consider AV canal defect with tetralogy of physiology. I would definitely go with the first, the 4 and the 5, and tricuspid atresia with VSDPS would be my the first diagnosis, followed by single ventricular tetralogy of physiology as number 2. And
Sir, tricuspid atresia has day 1 cyanosis, sir.
Yes.
That is
day 1 cyanosis. Day 1 cyanosis.
A1 sign.
It's something like admixture lesion because the whole blood comes to the left ventricle. So it's an admixture lesion, and they are blue from birth.
okay.
Okay. Now we'll go to physical findings and then take the discussion forward.
Okay, sir.
The tetralogy of fellow I am not considering because day 1 cyanosis. Other conditions we'll keep lower in the list, and then based on the physical findings we'll discuss further. Yes. Okay. Right.
Okay, sir. So patient is alert, cooperative, well oriented to time, place, and person. He is thin build. Height is 175 centimeters. Weight is 47 kgs. BMI is 15.2 kilograms per meter square of body weight. Body surface area. He is underweight. And arm span is 156 centimeter. Upper segment, lower segment ratio is 0.94. Saturation, he has central cyanosis, and all 4 limbs saturations around 82%. There is grade 3 pan-digital clubbing, conjunctival suffusion. There is no icterus, pallor, edema, or lymphadenopathy.
Okay.
I'll go ahead, sir.
Go ahead. Yes. Gaurav, would you like to discuss at this stage, or you would like to do it little later?
Later only, sir. Later only.
Okay. Right. Okay.
There is no evidence of any dysmorphic features, low hairline, skeletal deformity, or syndromic features. Patient is afebrile. Pulse is 84 per minute when I examine the patient. It's regular, bilaterally symmetrical, normal in volume without radiofemoral delay. Normal condition of vessel walls. All peripheral pulses are well fed. Blood pressure is 100 by 76 millimeters of mercury in both upper limbs and 106 millimeters of mercury systolic in both lower limbs. Respiratory rate is around 16 per minute, abdominal thoracic. Saturation, as I mentioned, 82% in all 4 limbs. JVP is not visualized.
Oh, yeah. So JVP is not visualized. So any clue to be taken from that?
Yes, sir. Indeed.
Yes, sir.
JVP not visualized.
Yes, sir.
The condition that we have thought of. Well, what
Yes,
is
sir.
JVP?
That then tricuspid atresia will have JVP.
Clue is it may be
Tricuspid atresia
intracranial.
is
Tricuspid
It may
atresia
be
can have.
intracranial. JVP may be intracranial. That's what we see.
What is the abnormality in JVP? What are the things that you should look for in JVP? Why are we worried about JVP in this patient?
Because we are thinking about tricuspid atresia, A wave should be prominent.
maybe we should comment this.
Is it a must? Is it a
A-wave?
must? Is it
No.
a must that in all patients with tricuspid atresia, A-wave should be?
So, sir, if
No, sir. If patient is in sinus rhythm, A wave should be prominent. If patient has undergone any procedure, palliative procedures, JVP may be altered, like
Yes.
in this patient.
Okay. Now I am asking a question. Can there be a situation where in a patient with tricuspid atresia, there is no prominent A waves? What is the single most important point which decides the height of the A wave in a patient with tricuspid atresia?
RA compliance.
Not
R,
R.
RV compliance.
No,
RA
tricuspid
compliance.
Tricuspid
RA
atresia.
compliance.
Anybody? Somebody was answering.
It's like a tricuspid atresia is usually associated with ASD, so
Ah,
then you will not get it.
with a large ASD. If
Yes,
there is
sir.
a large ASD in the patient with tricuspid atresia, A waves may not be prominent. In that situation, what decides the height of the A wave?
Yes, the LVEDP.
Very good. LV and diastolic pressure. The one which
Nice.
decides the height of the airway will be the LVEDP. It has nothing to do with the right ventricle. So
Yes,
in
sir.
a,
Yes.
but if the ASD is restrictive ASD, then you can immediately get a large A wave. But if the ASD is very large and there is a free flow of blood from the right atrium to the left atrium, then the height of the A wave is decided by the left ventricular and diastolic pressure.
Understood.
Okay. So, in a patient who has been operated upon, we carefully look for JVP. Why? Patient has been told that he requires a stage procedure, and it is very important to look at the JVP, whether the JVP is elevated, what is happening to JVP. Why it is so, Gaurav?
So it will tell us about the RV failure, sir. If RV is failing, that is one of the.
In this, we have to see whether so there is the shunt, BP shunt, if done, that is whether functioning or not.
British and may not give rise to any JVP. What should give rise to JVP elevation?
Because it is artery which is connected in BT shunt, so it may not give rise to it may not give us a clue.
Vascular resistance per se, in case of BP shunt.
Now, what is the venous connection which can create which can cause significant elevation of the jugular venous pressure column?
The pulmonary AV tissue.
Eh?
No.
Surgical shunt which can give venous shunt, sir is asked.
No. Venous shunt which can sometimes give rise to as a complication. We carefully look for any JVP elevation, and especially if the patient's pulmonary vascular resistance is slightly going up, then the patient's JVP can be significantly elevated.
Glenn.
Beg your pardon?
No.
What is
Glenn. She said Glenn, sir.
Yeah, Glenn procedure. Oh, all right. To some extent, it is correct. Monika, would you like to discuss that point? Monika, would you like to discuss?
Yes,
how
sir. Glenn is in Glenn shunt. What happens is SVC is connected to the pulmonary artery. So when pulmonary artery is pressures are going up, your superior vena cava pressures as well as jugular venous pressures will go up. They may go so high, they may be intracranial and may not be seen on clinical examination, general clinical examination.
it is very important to carefully look for it, because this is one clue for us to decide whether the shunt which has been done is functioning well or the patient has developed a complication. That is one reason. What is the other reason for the JVP to get elevated in a shunt, Glenn-like shunt procedure? You are right. At the anastomotic side, can something happen?
Yes, sir.
Thrombosis, sir. Thrombosis.
Have stenosis at the anastomosis.
Yes. Another complication is that there can be stenosis at the anastomotic site, and that can also give rise to prominent significant JVP elevation. Okay. One point we failed to discuss, Gaurav. This patient had 2 episodes of palpitation, and what do you think
Yes,
is
sir. Yes, sir.
that we discuss? We'll take 1 minute to discuss that point. What do you
Yes,
think
sir. Yes, sir. Yes.
cause of palpitation?
Sir, it was a regular palpitation. I asked also, madam, during history time. So most probably it was a atrial tachycardia.
Why can't it be beat?
So there was no loss of consciousness. There was no loss of consciousness.
But both the times the patient was
hemodynamically unstable. Okay.
because the patient was given shock. The DC cardioversion was done in both occasions. Obviously, meaning that it was a serious form of arrhythmia, and immediate intervention was required, and the patient was about to go into some hemodynamic disturbance. And she
The high rates of atrial tachycardia can also be hemodynamically unstable.
Yes, it is possible, but then we don't immediately go in for a electrical patient with atrial tachycardia. And also, we asked about the medicine she is taking, and she told that
Caldron, it was Caldron, I think, most probably.
From the
dosage pattern, it looks like
it's
it is amiodarone.
It's like amiodarone. So I think we have to think a possibility of ventricular tachycardia. If it is ventricular tachycardia, what is the reason why the patient has developed a ventricular tachycardia?
Surgical scar.
Usually, as you rightly said, the atrial tachycardia, atrial arrhythmias are much more common in Glenn procedure, where the superior vena cava is connected to the pulmonary artery. The arrhythmia that you get is mostly atrial arrhythmias, but ventricular arrhythmias are a bit uncommon. And ventricular arrhythmias usually happens in procedures which are done on the ventricle, especially right
ventricle. Yes.
When something is done on the right ventricle, the patients can get ventricular tachycardia. But whenever the Glenn procedure is done, arrhythmia that we expect is an atrial tachycardia. So I think we have to keep our mind open. I would think mostly from the history and the medication the patient is taking, it is ventricular tachycardia. But what I expect is an atrial tachycardia. And also the treatment given also points more towards a ventricular tachycardia, which has given rise to hemodynamic disturbance. So
sometimes for rate control we give Caldron also, sir. Sometimes in adult patient we give Caldron.
Point we should remember, when patient is given, patient is already, we are thinking about the Glenn shunt. Okay. So if you give any medicines intravenously, they won't reach the circulation. Getting my point?
Are you getting the point, Gaurav?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Why it will not use the circulation? Explain it.
So from the venous side, it will first go to the left side.
Monika, you give an explanation to him.
Yes, so it's a Glenn shunt, no? So SVC is connected to right pulmonary artery.
Right pulmonary artery, yes. So it will go to the left. Yes.
It will go to right pulmonary artery. PS is there, and anyways, it will go to lungs. However, it won't come to the systemic circulation. And what all medicines which we can give immediately? Adenosine, right? If you are considering SVT. So if you give adenosine, it won't reach the circulation. The half-life is only 9 seconds.
It can reach, but it will be delayed. Sometimes you may not get delayed. You may not get the desired.
It can reach the circulation, but it won't reach it.
It will be delayed because there is no drive of blood in the pulmonary artery, because it is the venous blood which is pushing the pulmonary flow. So it will be quite delayed in the pulmonary circulation, and especially if you are using adenosine, it may reach the left side quite delayed, and by that time the adenosine effect might be gone.
Actually, they tried, sir. They tried one dose of adenosine. Then they shocked. Later we came to know, after I discussed this case, later we came to know. I went and asked emergency people.
Oh, I see. Okay, now
it was mostly atrial tachycardia only, ma'am, then. It was atrial tachycardia then, or?
We'll see what it is. What do you think it should be?
Atrial tachycardia, adenosine is a good treatment.
Or supraventricular tachycardia. But
it is in supraventricular tachycardia, the re-entry tachycardia, that adenosine is the correct drug to use. But in a patient with atrial tachycardia, then what do you use? What are the drugs that you use mainly to bring down the heart rate in a patient with atrial tachycardia?
Beta blockers.
Ibutyl.
Okay, beta blocker can be used, but we prefer some other drug. Monika?
Ibutyl, flecainide, we can
Yes,
use.
these drugs can be used, or you can also use intravenous verapamil. You can use
Where, yes.
diltiazem. All these can be used, and of course, beta blocker also can be used in if you think that the other drugs are not effective, you can definitely use beta blocker. Metoprolol can be given intravenously. That also will produce an AV block, and the ventricular rate can definitely come down. So that can be used, but that is not the preferred drug. As we have said, there are other drugs, class 1C antiarrhythmics can be used, and also you can use verapamil, diltiazem drugs, which also can bring down the ventricular rate. Okay.
Sir, flecainide is structurally normal heart, no sir? Flecainide for structurally normal heart here.
No,
Heart is
sir
not.
asked only for A. Can we use
Okay,
it?
okay,
That's why.
okay.
Only problem is that you should be careful in using flecainide because in a diseased heart, if you use flecainide, that can give rise to
AV nodal block.
and
A, A 1:1 condition. 1:1 condition.
sometimes it can give rise to even proarrhythmia, and the
Yes.
patient is going for torsade.
Yes, sir.
So that,
Always with a beta blocker, sir.
It should always be given with with one AV nodal block agent.
yes. Okay, right. Go ahead.
Okay. So from this JVP is not visualized. So we have reached some. Maybe it is Glenn. Fundus showed increased tortuosity of retinal vessels.
Okay, what does that mean? Fundus shows increased tortuosity of retinal vessels. Gaurav, what is the relevance and what is your interpretation?
So is it due to
Is Saroj there? Saroj is the one. So Saroj also can discuss.
yes?
She is answering, sir. I think.
Yeah, yes. Gaurav, you continue.
Yes, sir. Yes, sir.
What does the increase?
This is hypoxia cyanosis leading on to increased is one of the, or ice or there's a
Okay, Saroj, would you like to address this problem? Increased tortuosity of retinal vessels. How will you interpret it?
The increased tortuosity of retinal vessels suggests that either patient is having polycythemia or the intra ocular vessels have got a higher pressure. So because we have done shunt surgery, so that may have been reflected.
Okay, Monika, would you like to explain what is the tortuosity of retinal vessels? Does it give any clue?
Basically, in chronically cyanosed patients, there is vasculopathy, there is endothelial dysfunction, which leads to chronically cyanosed patients with any cyanotic heart disease. Long-term cyanosis will give rise to changes in the retinal vessels in the form of increased tortuosity. Sometimes they may be dilated due to endothelial dysfunction, vasculopathy.
And also in shunts where the systemic vein is
Increased pressures.
on the artery, when the pressure goes up, that can give rise to tortuosity of the retinal vessels, especially the veins. If you can differentiate that there is the engorgement and tortuosity of the retinal veins, especially, that may give you a clue that probably the patient might have undergone a shunt procedure from superior vena cava to the pulmonary artery. Okay, right, yes. So here we just clue that it's only tortuosity of retinal vessels. It is not clearly mentioned whether it is the venous system or the arterial system which has become more tortuous. Okay, right. Go ahead, Monika.
Yes, sir. So we'll go ahead with cardiovascular system examination, inspection and palpation.
Yes.
The precordium is bilaterally symmetrical, no precordial bulge. There is mid-sternal surgical scar extending from suprasternal notch up to the epigastrium. Apex pit is felt in right sixth intercostal space at mid-clavicular line.
Oh, so it's a dextrocardia. So
Yes, sir.
if you had asked a question whether the patient is having dextrocardia, probably I don't know whether
would have benefited.
yeah, whether the mother or then our discussion on the history part would have been much better. So,
Yes, sir.
so this patient has got dextrocardia. So, sometimes I always ask the patient, mother or the patient themselves, whether some doctors told them whether the heart is on the wrong side. So that may sometimes give you a clue to the what maybe the patient is what the patient may be having. Okay, right. So the patient is having dextrocardia. Very good. Okay, yes.
So it's a LV type of left ventricular type of apex, localized with lateral thrust and medial retraction. There are no other visible scars or sinuses other than the mid-sternal scar.
Okay, Gaurav, what are the cyanotic congenital heart disease where you can get an LV type of apex?
It's a tricuspid atresia, sir.
Very good.
Single ventricle.
Very good.
And then
AV canal defect.
AV canal.
Okay, anything else?
DRV with restricted VST.
DRV with VST, yes. DRV with restricted VST, yes.
Very good. DRV with restricted VST, very good. What else?
Aortopulmonary collaterals. Top with aortic regurgitation.
Yeah, so
Hoffman's
of course in adults you can get aortic regurgitation, top with aortic regurgitation, and also truncus arteriosus with truncal regurgitation. So these are the conditions where you can get an LV apex in a patient with cyanotic congenital heart disease. Gaurav, can you just recollect so that we are sure about it? LV type of apex in cyanotic congenital heart disease. One.
First, truncus arteriosus.
No, don't say truncus arteriosus as the first one. Start with the
tricuspid atresia. Yes, yeah. Tricuspid atresia. Yes. Then was a single ventricle.
Very good.
Then was the DORV with restricted VST.
Very good.
And then was truncus arteriosus, and then was AV canal defect.
Very good.
AV canal.
And also you can use the Atresia phyllo with aortic regurgitation, especially in adults. About 10 to 20% of patients with Atresia phyllo can develop aortic regurgitation, and they can have an LV type of apex. So that also should form part of your thought process. Okay, very good. Yeah. Okay, so we could have got a clue if we had asked the patient. Did the patient know that he has got a heart on the right side?
No, sir. No, sir.
Okay, so then we will not have got a clue. Okay,
they are from low socioeconomic strata, sir. A mother hardly knew that what kind of heart disease they didn't know at all.
Okay. So even they did not know that the heart is on the right side. Okay, usually.
No, not really.
Okay, right. Okay, go ahead.
It was difficult for me to dig out this much history.
Oh, I see. Okay.
Yes, sir.
So whenever the patient is having dextrocardia, obviously you must be ready for a complex congenital heart disease.
Yes, sir.
Especially if the dextrocardia is associated with
levocard.
No, normal
So
size.
normal
situs. When there is a normal situs or a normal situs, then you should always think of a complex congenital heart disease. Okay, right. So go ahead, sir. We'll discuss further. Very good.
Yes, sir. So I'll go ahead, sir.
Yes.
So percussion. The lever dullness is in left 6th intercostal space in mid-clavicular line. Lever span is 6 centimeters. Stomach tympani is on the right side. Right heart border corresponds with apex, and left heart border is just outside the left lower sternum border. Left second intercostal space is resonant.
So the patient is having a
dextrocardia with
situs inversus.
Yes, sir.
Okay, so that becomes usually when there is a situation where usually complex congenital heart disease is very not common. Okay.
Yes, sir. It's not common, but 90% of the patients will have normal heart.
Yes. Even when they have got a congenital heart disease, very often they are not very complex. Usually the complex congenital heart disease occurs when the patient is having dextrocardia associated with heterotaxy or maybe associated with situs solitus. So these are the situations where you can expect a major form of a complex congenital heart disease associated with dextrocardia. When it is true dextrocardia with situs inversus, very often they may have a normal heart, or even if they have got a heart disease, very often there may not be a complex one. Okay, but always there can be surprises. Okay, right. Yes. Go ahead.
On auscultation, the S1 is loud and the S2 is single. Hello.
Okay, very good. Yes.
And a grade 3 high pitch mid systolic crescendo decrescendo murmur is heard all over the precordium. However, it is best heard in the right second intercostal space with the diaphragm of stethoscope, and it is increasing on inspiration.
Okay. Gaurav, interpretation.
Yes, sir. Crescendo, decrescendo murmur.
Mid systolic crescendo decrescendo murmur.
Yes.
Mid systolic murmur or ejection systolic.
Mid-
You can say crescendo decrescendo is just a shape description.
Generally, this we have to increase the flow through the.
Why?
Where is this murmur coming? See, she has even said it is an ejection systolic murmur. When somebody says that there is an ejection systolic murmur, Gaurav, what all things you should conclude?
So is there obstruction to the?
No, it is
Obstruction.
nothing to do with obstruction. It is not important to have an obstruction. Ejection systolic murmur means it's a mid systolic murmur. It's a crescendo decrescendo murmur. And third, it is the murmur is generated because of the ejection of blood from one ventricle to a great vessel.
To the yes.
No, not to the other. One ventricle to the great vessel, corresponding great vessel. For example, LV to aorta or pulmonary artery.
RV2.
Or it can be in transposition, it can be from RV to aorta, or it can be from left ventricle to pulmonary artery. It only means that it is a mixed systolic murmur, it's a crescendo decrescendo murmur, and the murmur is produced because of the ejection of blood from one ventricle to a great vessel.
Great vessel, yes.
So here, from the description, where is this murmur originating from? Is it from the pulmonary region or from the aortic region?
So here is the dextrocardia in the right second intercostal.
Oh,
So it is pulmonary.
Correct.
she has also said that the increasing on inspiration, so it's a right-sided event. So we easily we can, and also this patient is having a tetralogy of fellow. The basic principle is that the basic principle is that in a cyanotic congenital heart disease, if you are hearing a rejection systolic murmur, take it as
PS.
pulmonary stenosis.
Yes.
Take it as PS.
Take it
Yes,
as,
yes.
irrespective where you are hearing, it is PS.
But sir, increase in inspiration means that VSD is because if VSD is there, then it should not increase in that.
Why VSD will have mid systolic murmur?
What are the types of murmur that you can have in VSD, Gaurav?
No, sir. VSD will be pansystolic, sir. Will be pansystolic.
Can there be any other type of murmur in VSD?
Yes, sir. Restrictive VSD can have ejection systolic. Restrictive VSD.
Early systolic murmur.
VSD patients can have early systolic murmur.
Early systolic.
Yes, sir.
This is
Not mid systolic.
more frequent in muscular VSD,
Yes.
where the early part of the ejection, the muscular VSD may be opened, and as the contraction proceeds, the VSD may be closed by the contracting muscles, and they can have only early systolic. And some other patients.
Yes, sir.
Some other.
Sir, my point.
Oh.
Yes. The increasing on inspiration means that septum is intact, so that was my I was thinking, sir. Increasing on inspiration. That is the.
That you have to interpret. Only it means that it's a right-sided event. So that is one question we have to think about. So mostly it is in right-sided events that you get an increase in the murmur. So I would whenever there is a description of a murmur increasing on inspiration, I would take it as a right-sided.
Right side.
Okay, go ahead.
There are no added sounds, and sir, click was not audible. Means there was no audible click as such.
Okay.
Okay. Sure. Now on other system examination, as I said, upper border of liver dullness was in left intercostal space, stomach tympani on right side, suggestive of visceral cytosyndosis. Respiratory system examination.
Monika, is there any pulsations felt on the liver, any systolic pulsations or pre-systolic pulsations felt on the liver?
Pre-systolic. They were there, sir, but I haven't mentioned here. They were there.
Which pre-systolic pulsations of the liver?
Pre-systolic pulsations, yes. There were pre-systolic pulsations of the liver were there.
Oh, so that will.
But they were not very badly, means very prominent, but they were there. I haven't mentioned, just mentioned the situs.
Okay.
I mentioned, sorry.
Okay, yes, so that is another clue that we can think about pre-systolic pulsations. What does the pre-systolic pulsation mean, Gaurav?
So there is increased in
RA pressure.
RV pressure.
No, not RA.
RA pressure.
The pre-systolic event is, especially if you are feeling a pre-systolic event, you should start thinking that there's a prominent A wave. And if you are getting a systolic pulsation, then you should think that there's a prominent B wave.
Yeah.
So you have to look. Pre-systolic pulsation indicate prominent A wave, and systolic pulsation indicate prominent B wave. Yes. Okay. So nothing. Okay. Now coming to the diagnosis. Before we look at the ECG and X-ray, we'll have a provisional diagnosis.
There is no diastolic murmur also, no, man? No diastolic, no diastolic.
You should describe only one murmur.
Okay.
So, do you want to change your diagnosis, or you think that we have made the correct diagnosis? Of course, dextrocardia we are not thought of. Okay,
hemodynamically same.
What is your diagnosis? You discuss the diagnosis and tell me the result.
First, history-wise, it is first we'll go point-wise, sir.
Okay.
History-wise, there is cyanosis since birth.
Yes.
So we have kept our diagnosis of tricuspid atresia and admixture physiology, tricuspid atresia and single ventricle as our first diagnosis.
Yes.
Then when we went on examinations, there was LV type of affects. Again, these two diagnoses are still there.
Yes.
Then because patient has cyanotic spells, it is a VSDPS physiology. So both can have VSDPS physiology.
Yes.
So these two diagnoses, I think all in all, dextrocardia with tricuspid atresia VSDPS or dextrocardia with single ventricle PS can be, means we can reach this from our examination.
And do you think that you would like to consider a possibility of single ventricle with VSDPS with transposition of great arteries?
No, in this dextrocardia, whenever, sir, when dextrocardia with transposition and dextrocardia with normally related great arteries or malposed great arteries, the murmur of the PS murmur, what we are getting is in the right second intercostal space.
That's right. So, that is especially when there is corrected transposition. In the regular transposition, it can still be heard on the of course, the site of the murmur is quite consistent with the dextrocardia physiology. So dextrocardia, yes, that's fine. I'm just asking you, do you think that if you are considering single ventricle, you would like to think of a possibility of associated transposition of great arteries? Or I would like to ask, is single ventricle associated with transposition of great arteries?
I'm not sure, sir. I mean, I haven't considered this possibility, but it can happen.
Yeah, it's single. Whenever you are thinking of single ventricle, always you can discuss a possibility of transposition of great arteries. In the situation, how do you diagnose transposition? Because it's only a single ventricle. How do you diagnose transposition in a single ventricle? By two ways. One, many of these patients with single ventricle, mostly about 90% of situations, it is the left ventricle which forms the single ventricle. And these patients sometimes can have a rudimentary infundibulum. And that infundibulum will represent the right ventricle. And if this infundibulum is connected to the aorta, then you consider that the patient is having transposition. With
Sir,
this,
one second, sir. Can you repeat, sir?
yeah, in patients with single ventricle, usually it is the left ventricle which forms the ventricle,
Yes, sir.
and then the transposition can be thought of if these patients are having a rudimentary infundibulum which is connected to the aorta. And this can happen in I forgot the percentage, but in a good proportion of patients with single ventricle, you can have transposition physiology, and this is diagnosed by finding that the patient is having a infundibulum which is connected to the aorta, and of course the pulmonary artery is connected to the to the ventricle, to the same ventricle. So in a patient with single ventricle, you can have a transposition physiology also. And second method to differentiate is that by looking at the relationship between the aorta and the pulmonary artery, and in transposition physiology, the aorta will be anterior to the pulmonary artery. So you look at 2 points: one, if the infundibulum is there or not, and whether the infundibulum is connected to the aorta. Two, the aorta is anterior to the pulmonary artery. So in a patient with the single ventricle physiology, you can always discuss the possibility of a transposition even before you see the echocardiogram. Echocardiogram will definitely sort out whether it is a transposition relationship or not, whether the vessels are transposed or not. Okay, right. Go ahead.
Sir, here the second intercostal space was resonant in percussion, ma'am. So that can also give us a clue that it is not. Here in our case, sir, second intercostal space was resonant on percussion, ma'am. Hello?
Yes.
Yes, it is resonant.
It was resonant.
That obviously means that also may be another clue that the vessels are anteroposterior. When the vessels are totally anteroposterior, there won't be any dullness of the intercostal space.
Yes.
So we'll keep these minds open so that when we look at the echocardiogram, we look at every point. See, the idea of looking at thinking for a differential diagnosis, thinking broad, is that when we are looking at the electrocardiogram, when we are looking at the X-ray, and also when we are looking at the echocardiogram, we look for all possibilities. Okay, Gaurav, say from this point we have thought that most likely we would like to have, we think our original diagnosis, we are retaining it, and on top of that, because of the dextrocardia, we can always expect a complex anomaly, and so we should keep our mind open. And which investigation would you like to have, whether it is a ECG or X-ray?
Something.
Sir, first X-ray, sir.
You would like to have the X-ray first. Why do you want to look at the X-ray first?
Because ECG already will have this in dextrocardia.
Why do you want to? In the ECG, what are the definite clues that you will look for based on
LVH, left axis deviation with LVH, sir, for tricuspid.
Left axis deviation with LVH, and no right ventricle at all. So that is the most important thing that you have to look for, especially when you are thinking of single ventricle as well as tricuspid atresia. So I would
Himalayan P waves.
Yes, I would have preferred to look at the electrocardiogram first. Look at the X-rays. So shall we have a look at the electrocardiogram, Monika?
Yes, sir. This is the X-ray, ECG or X-ray, sir. Which one you want?
I would like to have the ECG first.
Okay. This is the ECG.
Yes.
This is a left side ECG.
With the, do you have the ECG with the reverse limb leads as well as with the?
I have, sir. But this after this I'll show.
Okay. Okay. I interpret the ECG. Is it a true dextrocardia, or is it the right atrium is on the left side and left atrium is on the right side, or right atrium is on the right side and left atrium is on the left side? Gaurav.
Sir, P waves we can see, sir, it is negative in lead 1.
Very good.
But it is positive in lead 2, 3 and
lead 1 is
AVF.
Lead 1 is
lead 1 is negative, and AVR it is positive, and AVR it is positive.
Okay. So is the right atrium on the right side or right atrium is on the left side?
Right atrium is on the left because
Yeah,
lead 1 is negative.
Yeah, it's negative, so the right atrium is on the
Left side.
Left side. Left.
Okay, yes. And is it the really dextrocardia or dextroposition?
The real dextro.
It's a dextrocardia.
Real dextrocardia. Real dextro.
Why?
Sir, we can see the see from V1 to V6, we can see the decrease in the R wave.
Very good. The R wave is decreasing in size from V1 to V6,
Yes.
and you don't have the classical LV morphology which can be seen
Yes.
right on the V4, V5, V6 if the left ventricle is on the left side. So it is left ventricle is on the right side and the right atrium is on the left side. So it is
Yes.
fully transposed. So, it is a dextrocardia is like the true dextrocardia, but the patient is having complex congenital heart disease. That's a different question. Okay, right. So can we have the
Sir, one more.
One more finding is there, sir.
Yes, sir. One more. I'm telling. Ma'am. It is that you see this delta waves are seen. Delta wave.
Correct.
delta wave? Yes, I agree with you.
Delta wave. Yes.
Delta wave and lead one and it's clear in AVR. I think I agree with you that there's a delta
Yes.
wave.
No, V1 and V2 also very clear. Delta wave.
All leads, it is almost all leads it is seen.
Most prominent I thought was in AVR is very clearly seen.
Yes, sir. AVR.
V1 and V2 most.
Lead 2, you can see a notch also.
Yes. So I think that also an important point. What are the conditions when you get WPWO in a congenital heart disease?
Absence.
This is well described.
Absence anomaly, sir.
This finding help us to differentiate between single ventricle and tricuspid atresia?
Yes, sir. It is more
Yes.
common in tricuspid atresia.
Very good, excellent. It is more described in tricuspid atresia than in single ventricle. So this is an additional point for us to think more in favor of tricuspid atresia. Okay, very good. Yes, go ahead.
So this
No. We like to see the
X-ray.
correct. I'll show the X-ray, sir. It's in the previous slide.
yeah.
So this is chest X-ray. Gaurav will describe.
Yes, sir. Yes, sir.
Yes, ma'am. Yes, sir. So chest X-ray, PA view. Tricuspid inverses, we can see, sir, gastric shadow on the right side.
Okay, very good.
And sir, we have
also the apex of the left ventricle is on the
right side, sir. Right side.
because the right side dome of the diaphragm is at the
Lower level than the left side.
lower level. Very good. Yes.
And it's a post-op film, sir. We can see the external sutures also.
Yes.
1, 2,
But
4 sutures we can see.
Whenever you are looking at
Yes, sir. I'm coming to it, sir. I'm coming.
Yes.
Sir, it is borderline cardiomegaly, so 50% borderline only, sir.
think that
Not really cardiac.
do you
Not
in
yes.
our diagnosis we have thought of the tricuspid atresia, we have thought of the single ventricle. So
Yes, sir.
tricuspid atresia patients can which chamber can be dilated?
Left side, left.
Right atrium.
LV. Right, yes, sir.
You
Right,
should
yes.
definitely make a
Yes.
comment about the right atrium. You should make a comment
Yes,
about
sir.
the pulmonary vasculature. You should comment about the relationship of the great vessels. All those things should be commented.
Also from ECG, we have concluded that RA is on the left side.
Yes, ma'am. Yes. Now we can see it. Now we can see RA is.
Can you see RA is enlarged?
Yes. It is occupying about 3 intercostal space. Sir. RA is a.
Yeah. So there is a enlargement. There is also a clue for us to think that we are on the correct track. So R is
Correct.
enlarged. R is enlarged.
And there is acutely
Is
acute
apex RV type or
decelerate.
LV type? RV type or LV type apex?
So RV type, sir. Upturned apex. RV type.
This
It's
one.
not upturned.
No. Upturned. Sir, it will.
Globular.
Yes. Yes, sir. Yes.
It's not
It
upturned.
is.
Saroj,
Yes, sir.
Saroj also is there. Saroj, she can also give a comment.
Any type of effect.
Yes, I think if at all, I would favor it is an LV type of apex. classical RV apex is that it is upturned and the angle between the cardiac shadow and the diaphragm will be Gaurav,
Acute.
acute.
Acute angle, yes. Correct.
Yeah, it is not an acute angle. So I would think that is we are in the correct track thinking that it is an LV type of apex. RI is enlarged.
Tricuspid, yes.
And what the pulmonary artery segment? Is it prominent? Or then what about the pulmonary vasculature?
Sir, reduced pulmonary vessel.
No, but is there a difference?
Right.
Is there a difference between the two sides, right and left?
Yes, sir. Right is less than the left.
Yeah, it seems that there is a little more of blood going towards the left than to the right. So when the patient does that give us a clue that they might have shunted to the pulmonary artery?
Sir, there is slight rotation also, sir. There is slight rotation is there, sir. We can see.
Marginal.
That will always may be there because post-op patients.
So,
They will have distorted enough.
I won't consider many significant
Not
rotation.
that much of rotation.
Yeah, because see, if you look at the distance from the center to the clavicle, I think it's practically equal on both sides. So I won't be very harsh by saying that there is an off-centered filling. No, and it seems that the flow to the left lung is little more than onto the right lung. By
There is
look,
an extension of the trachea on the right side, sir. Very well seen, sir.
beg your pardon?
Indentation of the trachea on the right side, sir.
That's correct. That's correct.
Yeah. So there
It's
is
not very prominently seen, but it is correct.
So it is clearly seen that there's a indentation of the trachea. What does that mean, Gaurav?
sir, right aortic arch, right side.
Yes, right aortic arch. And right aortic arch, what are the conditions in which you get right aortic arch? Mention the conditions.
20% in top, sir, and 25% in tricuspid.
Eh?
Top will have no, sir.
40%
Top will.
8 to 25% in TOF,
Yes.
25% in TOF with pulmonary atresia, and maximum in truncus.
Very good.
Truncus.
Truncus arteriosus. How much percent? 40%.
40%.
Say tetralogy of Fallot is about 25 to 30%. Then pulmonary atresia 30 to 35%, and in truncus arteriosus almost 40%. So that is but when you look at the total number of patients with right side aortic arch, it will be tetralogy of Fallot, because tetralogy of Fallot is much more common than tetralogy with pulmonary atresia with So when you look at a patient with right side aortic arch, more commonly it will be tetralogy of Fallot. And then what about VSD? What other congenital heart disease?
VSD 2 to 5%, sir.
5%, yes. Even VSD can have what is the condition where the right side aortic arch is very, very uncommon?
TJ, no, sir? TJ.
Transposition. So I think by saying there is the right side aortic arch, we have to withdraw our diagnosis of. No. It's not the right side. It's the right side aortic arch, and the right side aortic arch is normal for this patient.
Dextrocardia.
Yes, because it is dextrocardia.
It's dextrocardia, and so the right side aortic arch is normal for this patient.
Yes, sir.
So still our diagnosis of the tricuspid atresia and single ventricle, and even single ventricle with transposition can still be maintained till we look at the echo. Okay, right. So I think there is a slightly more flow onto the left lung than compared to the right lung.
Yes, sir.
Okay. Okay. Do you have the reverse limb leads and right sided?
I have, sir, but I have to close my presentation. Then only I can show.
Okay. Right.
I haven't added them. Okay. But at the end of presentation, I can show.
Okay, right. Yes, go ahead. Echo.
Yes, sir. So this is echo. This is a subcostal view. You can see liver is on left side, and IVC is opening into a chamber.
IVC drains to what chamber, Gaurav?
IVC.
Yes, you recognize the RA by finding that IVC is draining to RA. Very rarely there can be anomalous drainage by IVC.
Into
Top to bottom you don't have, ma'am? Top bottom.
what? Sorry,
Top bottom images generally we have, no, ma'am?
upside down. Upside down.
Upside down.
It's a normal anatomical position.
Yes.
I am not trained like that.
Okay.
So I haven't taken.
Here,
Do that.
No, say that is in a baby, but in an adult congenital you can take the standard views and interpret, no problems. But in a baby, very often it is better to do in a position so that it is normal anatomical position. But
yes.
but in adult you can do similar to what we are doing in adult. Okay.
So IVC is opening into RA, and I put the pulmonary venous Doppler, and I'll go next.
And before that,
Recus.
okay, Saroj, would you like to give a comment?
Yes, sir.
The thickening of the wall, we can see the thickening of the wall.
No.
The next atrium looks enlarged and
Yes.
only single AV valve is seen, possibly, sir.
Correct. That is only single AV valve.
Yes, similarly. And also whatever you are
Seen, sir, most probably, sir.
very good. And also whatever you are looking at here, the chamber which is seen on the left side of the image seems to be a pretty rudimentary chamber.
Yes, sir. And sir, there is no flow through most probably there is a athletic tissue seen between this large atrium and the rudimentary ventricle.
Yes.
Very good, very good. Okay, go ahead. Next one.
So this is a parasternal long axis. Can you see
Yes.
the first image?
Yes.
Interpretation. What is the chambers that you are seeing?
So LA and LV, sir, single
Very
one.
good. LNLV, and also you can see a large vessel, a great vessel.
Large vessel.
We cannot interpret that great vessel because if we want to interpret it, we should see a little more distance from the great vessel. Whether it
And
is
sir, that great vessel walls are also not equally. Great vessel
Actually,
walls.
it's a very difficult window in these patients. No, they've been built. Literally struggle to get those windows.
actually.
And one more thing, sir, that antral mitral leaflet is thickened, sir.
Yes, it
Thickening
is
of the wall.
myxomatous.
Yes, I agree with you. There is
It is
some thickening.
myxomatous.
So there is some thickening and myxomatous degeneration of the anterior mitral.
Anteromitral.
That's there. Yes. Okay, now go ahead. The next view, any interpretation?
However, LV is opening into aorta. Okay.
No, I think I will not comment about aorta. Understand
Yes, sir.
bifurcation.
We see the walls. We see the walls also.
I have to decide which is the vessel. So that can be decided only if I can see the bifurcation. Otherwise, I will keep my comment hold till the time I get further views.
Bifurcation.
So,
This is
one thing we can say, sir, it is a single ventricle. That RGOT is not seen in this view.
Yeah.
We can see that.
This some RVOT is not seen, but some rudimentary ventricle is there, I think, in the parasternal long axis.
No, I think we have
Yes,
seen
yes.
already that one of the ventricle is rudimentary, and also we have seen that the atrioventricular valve which is opening to that ventricle is not seen. So our original diagnosis of tricuspid atresia is so far correct.
Yes, sir.
And LV function appears to be adequate, sir, from this frequency at least.
Yeah,
Because
okay. Yes, okay.
anterior leaflet is slapping on the.
Okay, what is the next view? What are the
Next view. Actually, sir, the bifurcation is seen. However, I could not get it entire view. Few
Okay.
clips are not playing.
oh,
That was the problem.
so the vessel which is bifurcating is rising from the LV or from the RV?
The vessel which is bifurcating is arising from RV, sir.
RV. So that there is no transposition. It is actually normal
Back
irrelevant.
post.
Okay. Okay.
But here this view, short axis, we can see aorta is malposed, sir. It is not transposed.
Oh, yeah. This is the short axis view. Yes. Yes. Aorta is anterior actually.
Yes, sir. It is malposed. It is not
This
transposed.
Oh, I see. So, did you carefully look for infundibulum?
Yes, sir. Yes, sir.
Also.
We have that view is not playing. I will
Oh.
try if it can.
Oh, so I think because looking at the position of the aorta, which is quite anterior, I am inclined
Yes, sir.
to rule out a possibility of associated transposition.
Correct, sir. But this small vessel you can see, sir, that's a bifurcation actually. I was not able to show. I will try.
Okay.
That plays.
Okay.
The
Oh,
videos were not playing.
So this is very clear now. I think Gaurav, you should be able to interpret it
Yes,
without.
sir. Yes.
So here things are very easy now.
It's a parasternal fourth chamber.
It's apical fold.
Apical full chamber view.
Yes.
Single bed.
I don't think it is single ventricle. I can see some symptom.
You can see the arthritic.
I don't think it's single ventricle or single atrium. Definitely there is a rudimentary right ventricle is seen.
Atretic tricuspid valve.
Yes, sir.
It well, and also you can see there are two atria, and probably some endotracheal septum is there, but not a continuous one. So there is a good mixing of blood between the right atrium and the left atrium.
Definitely.
So this
There is a VSD also. Not able to show that. Some
VSD has to be
clips
there.
are not. VSD is there in 2D we can see, but sir, those images were not playing.
Okay, right.
I couldn't call the patient again actually.
Okay, right. Yes. Go ahead. Any other view, Monika?
No, sir.
Okay.
Final.
Okay, right. So, Gaurav or one of you, Saroj or Gaurav, do you think what is your diagnosis, full diagnosis? Gaurav, you can, yeah.
Yes, sir.
How do you tell the
Sir,
diagnosis?
yes, sir. Situs inversus.
Yes. Some people say.
Dextrocardia.
Yes.
Sir, congenital. Madam has already posted it.
It does not matter. You can also modify it. She has
You
posted
can modify. This is my diagnosis.
Yes.
Does not mean that you should say that.
Yes, sir. Situs inversus dextrocardia.
I teach my students to say as congenital cyanotic heart disease as the first possibility, first diagnosis. Cyanotic congenital heart disease.
Yes, sir.
Then you can write situs inversus dextrocardia.
Yes, sir.
That's what I teach my students. Then start with saying there's a congenital cyanotic heart disease or congenital acyanotic heart disease. Then describe rest of things.
Sir, can we say it is a complex also because we have a complex?
Complex is not a diagnosis.
Yes, sir. Yes.
Complex is a term that we give when we find that transpository arteries or tricuspid atresia or tricuspid atresia with transposition. All these anomalies are there. Then we call it as a complex congenital heart disease. But ultimately, if you want to use that term, no harm. But that will not add anything to your diagnosis. Okay. So what is your diagnosis now? Complete.
Yes, sir. Cyanotic congenital heart disease with decreased pulmonary blood flow, soft physiology. Most probably tricuspid atresia, and with that VSD, I was not very sure, sir. So
we could not see any. It has to be
VSD,
there.
yes.
In a patient with tricuspid atresia, you expect a small VSD. So VSD will be there.
Yes.
What is the condition in which in a tricuspid atresia RV can be large? Gaurav?
Sir, if cannot.
No. When there is non-restrictive VSD.
More important than when there is associated with with transposition. Tricuspid atresia may be sometimes associated with transposition, and in that case, very often will have a large VSD, and the patients can have a significantly enlarged right ventricle. It may even be sometimes as big as or even bigger than the left ventricle. When in a patient with tricuspid, when you are suspecting tricuspid atresia and you find that there is a good right ventricular impulse, then you should always suspect a possibility of transposition.
Okay.
Okay, right. Yes, go ahead.
Post-palliative surgery, sir, most probably
Bidirectional gland.
Yeah, it's a bidirectional gland because
gland, yes, sir.
procedure. So the most likely it's a bidirectional and would be a gland procedure. Bidirectional gland. Okay, very good. Yes.
With features
So
of.
what is the arrhythmia this patient is most likely having?
Sir, he's having WPW syndrome with left lateral.
No, sir. The
Right.
patient is
Pathway.
probably having sir AVNRT with 1:1 conduction causing VT, sir.
Is it AVNRT or AVRT?
Sir, AVRT. Sorry.
AVRT.
So this patient is having WPW syndrome. So we should suspect the possibility of AVRT.
AVRT, yes.
Yes. Okay. So now coming to the description, short description about tricuspid atresia. Monika, you can give a short description of tricuspid atresia.
Okay, so tricuspid atresia is a congenital anomaly in which there is absence of the absence of the communication between right atrium and right ventricle. Okay.
The tricuspid valve is atretic.
So tricuspid valve is atretic.
Yes.
So there are multiple classifications for tricuspid atresia. However, the most commonly used is modified Kuhn's classification,
Yes.
in which we divide tricuspid atresia into three groups. So types: type 1, type 2, and type 3. Type 1 is tricuspid atresia with normally related great arteries. Type 2 is tricuspid atresia with transposed great arteries, and type 3 is any position other than transposed great arteries, that is malposed and associated with complex heart diseases.
So in our case, it is a type
3.
Type 3. Very good. Okay, go ahead.
So type 1 is further divided into 3 groups: type 1A, 1B, and 1C. 1A will have tricuspid atresia with pulmonary atresia. 1B will have tricuspid atresia with pulmonary stenosis. 1C will have tricuspid atresia with VSD.
Yes, very good.
Non-restrictive VSD. Now, type 2 again will have tricuspid atresia with transposed great arteries. So, we'll have type 2A with pulmonary atresia, type 2B with pulmonary stenosis, and type 2C with VSD with no PS.
Similar to type 1. The description, classification is similar to type 1, and type 2 also has got ABC. Very good, excellent. Type 3.
And type 3 is any position other than transposed arteries, like in malposed arteries.
Yeah.
Aorta may be anterior, but it will be normally related to respective ventricles.
Yes. That's what we got in the present case. Okay, right.
Yes.
Yes. And
Tricuspid atresia incidence is around 0.06 to 1.1% in general population. In India, it is around 0.3 to 0.4%, and this most common is type 1B, normally related great arteries with pulmonary stenosis.
those are
And
the
usually,
patients, the survival is maximum. That is why. See, survival
Yes,
is maximum when you have got a VSD PS physiology, that is the one which makes the patient survive. Yes.
yes, sir.
Oh, okay, right. Yes, go ahead. And now
Whenever the shunts are balanced, survival is better.
very good. Yes.
So, if patient has large VSD and non-restrictive VSD without PS, they will have. So, what are the common features of all tricuspid atresia? That cyanosis will be there most of the times. If there is large VSD, which with increased pulmonary blood flow, cyanosis may be minimal or negligible, which may not be clinically evident. Otherwise, cyanosis will be present. There will be single.
In a patient with, see, in general, whenever there is a pulmonary blood flow, It is the pulmonary blood flow which decides the cyanosis. If there is
Yes.
adequate pulmonary blood flow, then the cyanosis will be less pronounced compared to a patient who has got a reduced pulmonary blood flow. So that is a general principle. So, but
Yes.
in tricuspid atresia, even when the pulmonary blood flow is adequate, still they can be blue because of the admixture lesion. So bluishness can be detected in most of the patients with tricuspid atresia without difficulty. If the patient is not cyanosed or maybe mildly cyanosed, I would consider tricuspid atresia quite low in the list. It's not
Yes.
used. Okay, right. Go ahead.
So then hypoplasia means common features will include imperforate tricuspid valve, hypoplasia of right ventricle, interatrial communication, and communication between the systemic and the pulmonary circulation, but either via VSD or sometimes rarely by PD.
Okay, very good.
Okay, so variable features will be like ventricular-arterial relation. As we mentioned, that's how we classify tricuspid atresia. Then in 70 to 80% of the cases, arteries are normally related. In 10 to 20% of the patients, arteries will be transposed.
Yeah. Only point is that when they are transposed, very often the RV will be well developed also. That's one important point you should consider. When they are transposed, usually the RV is connected to the aorta and RV can be dilated, and sometimes even in tricuspid atresia, you may get an RV lift. So in all patients with tricuspid atresia, whenever there is an RV lift, you should consider an associate possibility of associated transposition. Otherwise, in a patient with tricuspid atresia, usually you don't get any parasternal lift.
Yes. Also, in normally related normally related great arteries tricuspid atresia, it is equally seen in males and females. However, the transposition with tricuspid atresia is seen mostly in male.
Now, usually, whenever you think of transposition everywhere, it is 4 is to 1, male 4 is to 1, male
Yes, sir.
4, female 1. Always it is like that. When a newborn baby, anywhere, when the baby, when the male baby is having deep cyanosis, you must always think of a possibility of transposition, because transposition 4 times more frequent in males than in females. Okay, right? Yes.
And I will go for
Yes.
natural history, sir.
Really.
Natural
Now
history.
you come to the management now. Quickly come to the management. And
Okay. Management wise,
Sir, ECG is pending, sir. That normal ECG. That madam told to put.
normal means you want to see right sided ECG.
Yes, ma'am. Yes, told.
Actually, one second. We'll just discuss the manner. It is a single ventricle physiology. So tricuspid atresia, we usually go for Fontan pathway. So
Very good.
Fontan pathway, how, what a, Gaurav, would you like to take or I should describe?
No, let Gaurav,
You discuss.
if he knows. Gaurav,
Yes.
can you discuss about the what do you mean by this bidirectional gland, and what is the single ventricle physiology?
That surgery part, I have not read.
Okay, okay. Then Saroj, would you like to discuss that point?
Sir, here because sir the VSD is very small and the RV is so rudimentary, sir, so we have to take that single ventricle physiology. Sir, we cannot have a biventricular correction, sir.
Very
So,
good.
sir, we have to go for a single ventricle repair. And for
Yeah.
that, sir, we have to do, Glen followed by Fontaine, and then, total cardiac intracardiac repair, sir.
And also the blood is
Total intercardiac repair is not done.
No, not possible. Sorry.
No.
We have to go for a first, sir, Glen followed by Fontaine.
Already Glen is done. So Fontaine.
Now Fontaine
total venous blood should be directed towards the
towards the
pulmonary artery.
artery, sir.
Pulmonary artery, and the right side of the right atrium, right ventricle is actually excluded from the circulation. Of course, there is some amount of blood will come to right atrium through the coronary sinus and all that will flow into the left atrium and also will go to the left ventricle.
Yes, sir. So sir,
most
we have to search for the all 10 criteria for the before doing the Fontaine, sir.
Not all 10. They were described earlier. Those are called as Chaucer's 10 commandments for
Yes.
Fontaine.
Yes.
And what are those commandments? I'll just quickly revise it.
Yes.
Age 4 to 15 years. There's normal sinus rhythm, normal systemic venous return, normal atrial volume, normal LV function, and mean pulmonary arterial pressures less than 15, and index PVRI less than 4 Woods units, and LVF around 6 normal, that is 60%, and one more is there.
LVED.
Pulmonary artery to aorta ratio of more than 0.75, and absence of competent mitral valve, and what is it?
Absence of competent mitral valve.
No, not absence of, sir. That is competent mitral valve, absence of some pulmonary valve deformity.
Yes.
Yeah.
See, all these things may not be very important, but most important thing is that pulmonary the pulmonary vascular resistance is extremely important, because
Yes,
if the patient has developed some degree of pulmonary vascular resistance, and if you connect the venous system to the pulmonary artery, it is a catastrophe. That is one of the most important things. You should always ascertain that the pulmonary vasculature is normal.
basically only two criteria are used in now. There is severe ventricular dysfunction and elevated PVRI more than 4 Woods units are contraindicated.
Pulmonary vascular resistance is extremely important, and second is the LV function should be normal to accept this systemic circulation completely.
Yes.
Okay, very good. Okay.
Most of the surgeons actually, sir, I discussed with surgeons. So they said they don't even operate beyond 2.5 Woods.
Oh yeah, that's what I said. See, you said about the index, but usually that will be that way. See, when you consider index how do you convert pulmonary vascular resistance into pulmonary vascular resistance index?
We have to multiply
we have to multiply. So very often when you look at a child, the pulmonary vascular the body surface area may be 0.6, 0.7. So when you are saying that 4 pulmonary vascular resistance index means pulmonary vascular resistance can be even as high as 7 or 8. It's very unusual. So I was wondering whether that is a correct criteria or not. Usually we don't recommend any shunt procedure if the pulmonary vascular resistance has gone beyond 2. We caution, because when it's beyond 2, there is a good possibility that it may fail.
Yes, sir. Now that's all it is. But however, Fontaine's earlier means perioperative results are very good, and usually
they can develop a lot of atrial arrhythmias, and they can develop sometimes at the site of the anastomosis, they can develop sometimes stenosis, and these patients can go for systemic congestion. That's the problem. I have got 3 patients who operated, and all of them died around the age of 12.
Oh, really?
Fontaine surgery, sir. Post-Fontaine, sir.
Yeah, all 3 died. They developed systemic congestion, and progressively they deteriorated, and we lost them.
But sir, exactly that is what they say. Even if the perioperative mortality is very low, less than 2%, patients the late outcomes are not good because of delayed complications of Fontaine.
My experience with Fontaine has been that it is usually, as you rightly said, after delay about 12-15 years, they develop complications and we lose the patient.
The sudden cardiac death, or that was due to failure?
No, they progressively, they all the
lot of complications. Actually, that is one question. Sir, should just quickly I will revise for you. What are the late complications of Fontaine? Hello?
Yes, go ahead.
Yes.
So, we'll just quickly revise, sir. For left ventricle, it is a ventricular failure, ventricular dysfunction, and exercise intolerance. Then pulmonary circulation, what happens is there is a stenosis, dilatation, and formation of pulmonary AV malformations. Okay. Now, why I will tell you. Because it is a very high systemic venous pressure that will cause chronic liver congestion. and that will, release some hepatic factors which will lead to formation of pulmonary AV malformations. Okay. Now, IVC is heavily congested, so patient will have chronic venous congestion, chronic hepatic congestion, and they will develop sometimes even hepatocellular carcinomas. Now, most important is lymphatic system, how it is affected. So, lymphatic system will venous pressure is very high chronically. So it will have profound elevated venous pressures, lymphatic dilatation, increased flow across lymphatics, leading to multiple lymphatic complications, which include protein-losing enteropathy, then even pleural effusions, chiral thorax, and also, what is that? Plastic bronchitis.
In general, all these patients with tricuspid atresia after the bidirectional glen or Fontaine procedure, they progressively develop systemic venous congestion. All the complications are mostly related to that. And all my the three patients, they had a huge hepatomegaly, they had ascites, and they had JVP was inside the cranium. And in spite of adequate diuretic therapy and other forms of treatment, there was practically very little improvement, and they progressively deteriorated and died. So the ascites may be related to, they also had hypoproteinemia, protein losing enteropathy, all those things were there, and they had florid right heart failure. That's why I'm not responding to treatment. So that is what I have observed in all these three patients, where there was a florid right heart failure, and response to treatment is very poor, and they progressively deteriorate, and they develop, as you rightly said, they can develop even cardiac cirrhosis, and they can develop malignancy and arteriovenous malformations. All these things can happen because of the liver failure. The liver is congested, liver is enlarged, and they can go for cardiac cirrhosis. They can develop hypoproteinemia, ascites. All those things can happen. And very often it may behave something like constrictive pericarditis when you see the patient.
Yeah, yes, sir. Yes, sir. I have one patient.
Oh.
Ma'am, for this patient, we will need a mapping and that evaluation also of the pathway, no?
We have done
For
that.
W.
We have done that. We have done RFA for him, and he has the right ventricular posterior septal path.
That's the usual pattern. See, whenever there is a WPW axillary pathway in any patient with a structural heart disease, the pathway will go to the side of the structural heart disease.
Yes, sir.
So here is the tricuspid atresia, although it will go to the right side. That's the usual pattern. So when you are in doubt, you should again always think that if you are thinking of the axillary pathway in a patient with a structural heart disease, the axillary pathway should go to the side where there is a lesion. So Epstein's anomaly, it will go to right side. Tricuspid atresia, it will go to right side. Okay,
this is the issue.
This is much more easy.
Limblets are also interchanged. So now you can see a normal pattern.
Yes, it can be easily. Actually, in V1, in lead 1, the WPW can be easily.
Yes, sir. Yes, sir. Yes. No,
Yes.
Yes. And lead 3 and V1.
And madam has very beautifully made lead 1 as the rhythm lead, so it is very clear. Lead 1 is the rhythm lead.
Yes, that is only because, to see that delta.
Yeah, I think delta is
Yes.
without any difficulty. And you have put V2 as V1 and V1 to V2.
That actually is, sir, leads got interchanged, and that's why. Nothing.
Post-ablation ECG also you have, ma'am? Post-ablation ECG?
No, yeah, that ablation ke baad now, I was exam going during his, when he got ablated. So that he hasn't made, I have called him.
Okay, Monika, I think very good case, excellent case. We had a lot of discussion.
Thank you, ma'am.
And I think very good.
Thank you, ma'am.
I'm sure that our students benefited by quite a lot. So
Yes,
I think,
yes.
thank you, Monika, for bringing such a good case. Electrocardia was there, the Epstein's anomaly. Of course, the tricuspid atresia is there. and of course we could discuss it in the correct direction, and I think mostly we were right in our discussion. So
Yes, sir, I was really impressed when you reached the diagnosis right after history. You told tricuspid atresia right after history. I don't know how, but yeah.
no, because
Day one cyanosis helps, sir. Day one cyanosis helps.
yes, day one cyanosis and survival up to this age. So
And stage surgeries.
you had a PS, with a PS has to be there. So all put together, I thought this tricuspid atresia is the most likely diagnosis. Logically thinking, see, after all the diagnosis is logical.
Yes, sir.
It's a wonderful case. I think we thank you very much for bringing this case.
Thank you, sir.
And I think all our
Thank you, ma'am.
all our students benefited, especially Gaurav benefited the maximum.
Yes, sir. Yes,
He
sir.
should throw a party.
Thank you very much. It is still a learning process from me, and I am learning something new or the other thing new from you every day. Thank you so much.
Okay. Thank you. Thank you.
Thank you, sir. Thank
Thank
you.
you, sir. Thank you, madam.
Next week, what shall we have? Anybody else would ready to bring a case so that we can have an active discussion? Rajesh, is he there?
Sir, I may not be there next week, sir. I'm sorry. So maybe next week we'll catch up, sir.
Okay, fine, great. We will always like to have your involvement in the discussion so that it becomes more active. Very good. Okay. Okay, Gaurav, will you be able to bring a case?
Oh, this
Yes,
is
sir, I will try, sir. Yes.
CG.
Oh,
Luckily, I have.
Okay, thank you.
Good.
yeah. We can have that tachycardia strip also. Any comments, Gaurav? Would you like to give a comment?
Yes, sir. Yes, sir. Sir, we'll go with sir normal standardization and normal speed, sir. 25 millimeter per second and 10
Yeah,
mm
this
per.
is the left-sided one, okay? This is the left-sided one.
Yeah. The placing
Okay.
is the standard one with the normal upper limb.
Yes.
The left side position of the chest leads.
It's a broad, complex, regular tachycardia, sir, with heart rate around 150 per minute, no, sir? 150 per minute, yes. Heart rate is around 150 per minute.
Maybe slightly.
Broad, complex.
Yes. I'm looking for
With
use.
Because it is dextrocardia, sir, it is very difficult to apply the normal rules of tachycardia, VT versus SVT.
But then you should be able to get the PV.
no.
T waves are seen, sir, just after the termination of the QRS and starting of the T waves in lead 1.
In lead,
Lead 1.
One?
one or two.
No, lead 1.
Not
Just
Lead one, no.
just at the end of the QRS and the starting of the T wave, sir, a notch is seen.
Oh yeah, I think
That is
something is seen. I agree with you.
lead 2, lead 2 and lead 3
Please
also
don't
we can see.
see,
sir.
No.
Lead 2 and lead 3. Yes.
I think I go with Saroj that there is some minor notches seen just after the QRS complex in lead 1. And that's what we expect in a patient with AV re-entry tachycardia. It will be
Yes.
just outside the QRS complex. So
Yes.
I think I will accept that. I think there is a
Lead 2 we can see it distinctly, sir.
so there is some indication that there may be a PU there. I agree with you. And
Yes,
on lead 3 also there may be some clue that there may be just after the QRS complex some notch is seen. I think very good, excellent case.
And we could grab this ECG. I was there present and it happened. So
Okay.
that's how we could take it.
But the-
Post termination is there, ma'am? Post termination is
Post termination is not there.
One was-
But sir, actually I was exam going when it happened. He's a RFA ablation.
Monika,
So-
one question.
No, after this, the post that cardioversion, post cardioversion.
Why did you cardiovert this patient? Because the rate is only 150. And
He was
I-
hemodynamically
Yes, sir.
unstable, sir.
Oh, what is the reason?
He was unstable hemodynamically.
Reason. Because
Reason?
rate is only 150. See, anyway, in supraventricular
Hypotension
tachycardia.
was there with this. Even with this rate, he had hypotension.
Oh, that obviously means that he may be having some ventricular dysfunction also maybe.
He told
Because
that because of the Glenn shunt, the adenosine will not work. That's why, sir.
That is one most important reason, but hemodynamic compromise was the main reason.
No,
Means
this is what I was saying. That hemodynamic compromise, I don't expect in a patient with a supraventricular tachycardia of 150 rate.
But sir, he had.
Okay. So I must think that whether because of his complex congenital heart disease, whether he could not tolerate at all. I think that may be one reason, because he's having a basic structural heart disease, which is a complex one, and on top of that, tachycardia might have created the problem.
Decompensation.
Yes, because atrial support is gone. Lot of things are happening.
Yes, sir.
Okay, very good case. Thank you.
Thank you, sir.
Thank you.
So,
Wonderful discussion, sir. I enjoyed it, and I have to rush now for the airport.
I think you brought a good case, and it's a very good discussion for all our students, and I think great. Okay.
Thank you so much, sir. Sir, get back to you after a week, maybe
Okay, right.
next class.
Okay, Monika.
Yeah. Thanks. Sir. Bye.
Yeah, my Gaurav, would you
Yes, sir.
case for next
Thank you,
week?
madam.
Yes, sir. Yes, I will try, sir. Yes, sir.
Yeah, so that we can have an active discussion, and others also.
Okay, sir.
Arun Kumar, would you like to bring a case?
I'm not sure, sir. I'm not sure, sir. I'll see, sir.
You try to bring case so that if it is there, we can have a discussion. Or Gaurav also may bring a case so that we can have some.
Yes, sir. Yes.
Gaurav had actually brought a case previously. He had an active discussion.
Yes, sir.
I'm quite sure that Gaurav will not have any difficulty in walking through the examination. And the active interest that you are taking always keeps you get into a discussion. You can always discuss with confidence, and finally, what matters is your level of confidence in the discussion. I think you have done extremely very good. Okay, next week
Thank
we'll
you,
have,
sir.
Okay.
week after next we'll go to some of the basic things like some hemodynamic discussion or ECG discussion, whatever it is required. Okay, okay. So we'll presume that Gaurav will bring a case next week.
Yes.
Okay. Okay,
Thank
good.
you, sir. Good.
Good.
Thank you, sir.
Thank you,
Thank you,
sir.
sir. Good night, sir.
Thank you very much. With this, I am ending the meeting.
Oh,
Thank you.
Thank you. Thank you.